Good morning. I'm Dr. Kirihena, a Salon ENT surgeon, National Hospital of Sri Lanka. Today I would like to talk on diseases of the larynx. This is a structure of the larynx. At the bottom you can see the C-shaped rings of the trachea, and then above the first trachea ring would be the cricoid cartilage, which has a shorter vertical height in front and a larger vertical height behind, and which is attached to the arytenoid cartilage, and arytenoid cartilage attached to the vocal fold. And this is the thyroid lamina. This is a V-shaped cartilage, so you will not see the thyroid cartilage parts behind. And this is the hyoid bone, and this is the epiglottis. This is what you will see, how we will see the larynx on indirect laryngoscopy, or even using a 70-degree endoscope. This would be the appearance. These white structures are the two vocal cords, and the space is called the glottis space, where it enters into the trachea below. And these are the four false cords. Between the true cords and the false cord is the area called ventricle. And this is the arytenoid cartilage, and this is the area epiglottic fold. This is the epiglottis. This area is called interarytenoid area, and this is the posterior pharyngeal wall, and the space here will lead into the esophagus. Same is shown in the diagram here. The vocal cords in white, then the arytenoid cartilage, the area epiglottic fold, the epiglottis, and in front of the epiglottis, the tongue would be there. And piriform sinuses would be on either side of the larynx. This is the X-ray lateral view, soft tissue shadow showing the vertebral column, the skull here, the mandible in front here, and this bone is the hyoid bone, and this is the tongue base, and this area is the vallicular, and this is the epiglottis. This is all that is the laryngeal structures. Somewhere here you will see the vocal cords. And this is the trachea. Just note that the prevertebral tissue, the thickness is less than half the transverse diameter of the vertebrae under normal conditions. So this is how one should do in indirect laryngoscopy. We have a good light focused on the patient's throat, and patient is keeping the mouth open, relaxed and breathing through the nose, and while we are holding the tongue with a piece of gauze, we introduce the laryngeal mirror, and this is the laryngeal mirror. The vein here will be resting on the uvula, while we'll be looking, the light will reflect onto this and look and visualize the larynx below at 90-degree angle. This is a flexible endoscope. This can be passed through the nose and to examine the nasal cavity, nasopharynx, and also the hypopharynx and larynx. And if it is long enough, it can be used into the trachea, and we can also do the bronchoscopy with the flexible endoscope. This is a rigid endoscope, what we call the Hopkins rod lens system. It has a 70-degree angle to visualize the larynx. 0-degree angle and 30-degree angle endoscopes are used on the nose and the ear examination, but 70-degree required to check the frontal sinus as well as the larynx. This is direct laryngoscope. The metal laryngoscope to use is one need general anesthesia. It's because this will be pressing on the tongue base, and it's impossible for the patient to relax when the tongue base is pressed. They tend to get cough and gagging. This is the anesthesia laryngoscope, and that is also generally used by the anesthetists for intubation, but we can now sometimes use that to remove foreign body, visualize foreign bodies in the oropharynx and the hypopharyngeal area. Larynx can be affected by trauma, foreign bodies. Then there are congenital problems in the larynx that can cause stridor. Can be affected by infections like laryngitis, epiglottitis, tuberculosis, or the vocal cords. Then infection, chondritis, or the thyroid cartilage, which can be infective or autoimmune disease. Tumors can affect the larynx, can be benign or malignant. Trauma to the larynx can involve the epiglottis, can cause vocal cord edema, hematoma, supraglottic hematoma. Abrasions and lacerations can occur. Fractures of the thyroid skeleton can happen. Fractures of the thyroid bone, thyroid cartilage can happen. Larynx can be damaged due to shouting. That's what we call a voice trauma. So the teachers and singers might develop nodules in the vocal cords due to voice trauma. Surgical trauma can happen during intubation or surgeries on the laryngeal area. Smoking can damage the vocal cords. Corrosives, poisons, and hot fumes can damage the vocal cords. This is the appearance of a swollen vocal cords, what we call vocal cord edema. It can happen due to an allergy, it can happen in hypothyroidism, it can happen in trauma. This is a hematoma of the vocal cord. It can happen due to trauma. It can be direct trauma to the larynx or even voice trauma. Out of the congenital disorders affecting the larynx, the most commonest would be the congenital laryngeal stridor in the first year of life. Out of these, laryngomalacia is the commonest, which develops 3-4 days after birth. Laryngeal web due to the fusion of the vocal cords, subglottic stenosis, and subglottic hemangioma. All these can narrow the air passage in the newborn and cause congenital laryngeal stridor. Newborns can be also born with a bilateral vocal cord palsy due to brainstem problems, and this can cause bilateral vocal cord palsy can present as stridor. This is the endoscopic appearance of laryngomalacia in a newborn child. You see the epiglottis, which is folded like it's omega shape. And generally, it's a very tall omega shape epiglottis. And arytenoids are also sometimes very tall, and area epiglottic fold is short. So when the entire structure is very floppy. So when the child tries to breathe, this will collapse inwards and obstruct the air passage, causing the stridor. This is a picture of the laryngeal web. The vocal cords can be recognized in this area, and the entire anterior two-thirds is joined together by a web. So this will cause significant narrowing to the air passage, also cause voice problems. So if a child presents with congenital laryngeal stridor, child needs to do a fiber optic nasolaryngeal examination. And depending on the pathology, the child might need intubation, general anesthesia, and surgery. Infection that affects the larynx, the commonest would be acute epiglottitis. Generally, it happens in 5 to 6 year age group. 3 to 3 year age group. Hemophilus influenza is the commonest, and they present with stridor. And there's a thing called thumb sign in the X-rays that can be seen, but generally the X-rays are not done to diagnose it. But if the X-ray is done, we can see the very thick epiglottis, which appears like a thumb on the X-ray and lateral view. Epiglottitis can be very serious. Laryngitis can present with hoarseness of voice, can be due to viral, bacterial, or even chronic infection like TB or syphilis. Pericontritis of the cartilage can present with pain in the laryngeal area, can be due to trauma, infections, or even radiotherapy. Symptoms of laryngitis will be hoarseness of voice. Sometimes they might have pain and cough. Fever might be there. Ideally, might show inflamed vocal cords. Treatment of acute laryngitis may need antibiotics, analgesics, sometimes steroids. Nebulization and stimulation might be required, and antihistamines. And in worst case, where the stridor might be required tracheostomy. Epiglottitis is common in children 2 to 6 years age group. They can present with rapidly developing very high fever and stridor developing within hours. Child who has been apparently well in the morning might be quite sick by afternoon due to acute epiglottitis. And it's very important the child is handled, handling of the child should be minimal to prevent the laryngospasms and fatal cardiac arrest. If the child is sent for X-ray, then should be accompanied by experienced pediatric anesthetists with intubation facilities. Antibodies and steroids may be required. Tracheostomy may be required. This is the appearance of the acute epiglottitis. The very thick epiglottis and slough is seen on the epiglottis. This is another appearance of acute epiglottitis. Swollen epiglottis with pooling of secretions. And if the X-ray is done, this is the thumb sign there due to the swollen epiglottis. The swollen epiglottis will close the laryngeal inlet, might give us a stridor. Portions of voice can be due to vocal cord nodules, cysts or polyps, or tumors can be benign or malignant, or granulomatous conditions in the vocal cords like TB, syphilis, sarcoidosis, or vitreous granulomas. It can happen due to voice abuse, trauma, hormonal changes like hypothyroidism, infections, and vocal cord palsy also. So these are other causes of change in voice. Trauma can cause vocal cord palsy. Laryngitis can also cause vocal cord palsy. Tumors in the larynx, neck, thyroid, lungs, or mediastinum and brain can cause vocal cord palsy. Cerebrovascular accidents, myasthenia gravis, Guillain-Barré, aortic aneurysms, mitral stenosis, rheumatoid arthritis can all present with vocal cord palsy. It's a picture of vocal cord nodules. These are the nodules, and you can see the vocal cords also appear congested. It's commonly due to voice abuse. We see this in children who are shouting a lot, teachers, and also in singers. This is a vocal cord cyst, a smooth swelling and a lot of water underneath the epithelium. Treatment is surgical excision. On this side, the vocal cord appears normal. This is the polyp in the vocal cord, generally benign, arising from one side, so it might affect the other side. We had to exercise this to get a good voice. This is a case of laryngeal papilloma. You can recognize the normal vocal cords in front and some opening here, there for breathing. There's a irregular growth here on both sides. This is very typical of a human papilloma virus, laryngeal papillomas. Treatment is surgery. They might require repeated surgeries to get rid of the papilloma. Gamma interferon can also be tried as a medical therapy for recurrent human papilloma virus infection causing laryngeal papillomas. The patient's problem would be voice change and sometimes difficulty in breathing. This is the appearance of a carcinoma of the vocal cord. You can see the irregular growth here, where the other side is normal. Clinical presentation would be voice gradually developing hoarseness of voice. And if the tumor gets very big, it might obstruct the air passage into the trachea and then present a stridor. So in very advanced stage, laryngeal carcinoma will present a stridor. In the early stage, it might present with a hoarseness of voice due to the heavy vocal cord not working properly because of the growth. The stridor can be due to trauma, infections, tumors, bilateral vocal cord palsies. Unilateral vocal cord palsy never cause stridor; it only causes hoarseness of voice. It can be due to laryngotracheal stenosis and laryngomalacia or tracheomalacia, which are congenital. Tracheomalacia can be acquired due to long-standing coitus. Tracheostomy might be required in patients with severe stridor to maintain the oxygenation to the lungs, and tracheostomy might be required for long-term ventilation and also reduce the dead space. And for tracheobronchial toilet, in case of the lot of secretions in the tracheobronchial tree, it's easy to have a tracheostomy tube to suck out the secretions. You can never suck out the tracheobronchial secretions through the intact vocal cords. And if somebody is operating on the on the oral cavity or doing a major head and neck surgery, then tracheostomy might be required before starting the surgery, because endotracheal tube might interfere with the surgical field. To establish an emergency airway, cricothoracotomy, laryngotomy, or wide bore needle can be used, or emergency tracheostomy can be done. Routine tracheostomy is generally done under general anesthesia or local anesthesia, supine, with the patient supine and the neck extended very well so that trachea comes to the surface. Incision is generally transverse in adults, vertical in the children. Strap muscles are retracted in the midline. Thyroid isthmus is identified, either divided or elevated. An opening is made on the tracheal wall. It can be a longitudinal incision in children, or it can be a circular opening or a flap in adults with a large trachea. These are the various types of tracheostomy tube. You'll see that the tracheostomy tube has a kind of it's a bent tube. It's a kind of L shape. And there's a cuff here. It can be inflated from this end. And it has two flanges with the holes there. This is to put them ties or straps around the neck to secure it in the neck. See the mark here, the measurement. It mentioned 8 millimeters. That is the size of the internal diameter of this tracheostomy tube. Internal diameter, not the outside diameter. Is different from tube to tube. Is the internal diameter. So we must select an appropriate size tube depending on the size of the patient's trachea. This is another type of a tracheostomy tube. Here the flange is flexible, so it can fit into the various contours of the skin on the neck. It also has the diameters mentioned here on the cuff, on the balloon here, and it has inner cannula. So in case the tracheostomy tube get blocked while this whole thing is inside place, we can remove the inner cannula and replace it with the new inner cannula. Usually it comes in 2 sets of inner cannulas. So we keep one inside. When that is blocked, we can remove it and put the new one in. If you use a tracheostomy tube without inner cannula, if the tracheostomy tube gets blocked, we remove the entire tube and put a new one in. So the advantage of inner cannula is you just replace the inner cannula to unblock the tracheostomy tube. So after a few days of me having a tracheostomy, you will not need an inflated cuff. If the vocal cords are sensation is normal and the patient is not aspirating, you don't need a vocal cord cuff tracheostomy tube. So you can change to a non-cuff tracheostomy tube. Children generally have non-cuff tracheostomy tubes. They don't need cuff tubes. This is another non-cuff tracheostomy tube with the inner cannula. This is called thermovent. It's kind of a paper filter which we can connect these 2 types of paper filters. We can connect it to the tracheostomy tube opening, and the purpose of the paper filter or thermovent is one thing is to keep the warmth inside the trachea without losing it to the outside temperature. Also to keep the humidification inside the trachea to the maximum. So when you breathe in through the paper filter via the tracheostomy tube, the first breath would be all dry air. But when you expire, the water vapor in the expired air will wet the paper filter. And second breath onwards, you will be going through the wet paper filter. And so you are getting humidified air via the paper filter. So when you are provided humidified air to the trachea, then there will be less production of excessive secretions and less drying of the secretions causing crusting. So in the management of a tracheostomy tube, one should know the management of tracheostomy tube completely. It's very important as soon as the patient is brought to the ward from after tracheostomy surgery to see whether the tracheostomy tube is the proper place. Because it can get displaced. It might appear to be inside, but it may not be inside the tracheal lumen. It may be just inside the skin, but outside the tracheal lumen. So all you have to do is hold a piece of thread in front of the tracheostomy tube, and if the thread swings away with expiration, that means tube is in place. Also look for any neck bleeding and surgical emphysema of the neck, because these are the complications of tracheostomy surgery. And it's important to keep the cuff pressure below the perfusion pressure in the tracheal mucosa. So the perfusion pressure on the tracheal mucosa will be 25 millimeters of mercury. So the cuff pressure should be maintained around 20. If there are no facilities to check the cuff pressure, then it's important that every 1 hour cuff should be deflated for 5 minutes and then reinflated and kept like that for another 1 hour before deflating again. This is to allow mucosa to get blood. The mucosa that is in contact with the cuff or the tracheostomy tube to get blood during deflation. Any secretions in the tracheostomy tube and the tracheobronchial tree has to be sucked out, otherwise they can dry up and cause permanent obstruction of the tracheostomy tube or tracheobronchial tree. Might lead to collapse of the parts of the lungs if that happens, and also if the tracheostomy tube is blocked, they might go into respiratory distress and even cardiac arrest. So in order to avoid the crusting and the drying up of secretions, it's important to provide humidification. So the paper filter, which I shown earlier, called thermovent, is very useful. If the patient is in ICU, there's no problem. You can get the patient to humidified air. And when it is no longer required, you may try to change the cuff tube into a non-cuff tube. So if it's a routine tracheostomy for upper airway obstruction, then you can change to a non-cuff tube after 24 hours because then there's no risk of bleeding from the tracheostomy site. But if you have inserted the cuff tracheostomy tube due to avoid aspiration of secretions in case of patient with strokes, then we had to wait until the aspirations part recovers and the vocal cord, the laryngeal sensation returns to deflate the cuff. And whenever possible, we must try to downgrade the tube and move into a fenestrated tube. And when it's no longer required, we must try to decannulate. So if the cause of the tracheostomy tube insertion was upper airway obstruction, the upper airway obstruction is no longer there, then we can decannulate. So what are the complications of tracheostomy? The early complication would be the bleeding from the tracheostomy wound, can be from the inferior third veins, anterior jugular veins, or maybe blood vessels in the tracheal wall. And so during surgery, we make it a point to tie off all the veins so that they may not give us troublesome during the bleeding during the post-op period. Aspiration of secretions into the tracheobronchial tree can happen. Tube can enter the wrong space. It can get dislodged out of the tracheal lumen. It might come to lie between the anterior tracheal wall and under the skin. So you think it's inside the trachea, but actually it's inside the skin, but outside the tracheal lumen. So it might be the wrong passage. And you can verify it by holding a piece of thread in front of the tracheostomy tube opening. So if it swings with expiration, we know it's in the correct place. It's not. It's not in the trachea. So we have to take it out and put it back again, maybe under endoscopic guidance. Surgical emphysema of the neck and chest wall is a complication due to leakage of air, or it can happen because the lung apex got damaged. In which case, it might even lead to pneumothorax. So surgical emphysema feel like the neck appears swollen, chest appears swollen, and you feel the crepitus when you palpate the skin. Late complication of tracheostomy would be infections in the tracheostomy site, granulation tissue developing in the tracheostomy opening site. And once the tracheostomy tube has been removed, also the opening may not close sometimes spontaneously, and they might end up with the tracheal fistula. So the problem is always mucus secretion from the trachea will come out onto the skin. It's a social embarrassment for the patient. Tracheostenosis can happen as a complication of tracheostomy if the cuff has been kept inflated above the perfusion pressure of the mucosa. If there has been trauma to the tracheal mucosa and cartilage with the lower end of the tracheostomy tube. So I have shown you some non-neoplastic conditions in the larynx like the polyp cyst and TB, syphilis, sarcoidosis, and vaginas can also present as granulomatous lesions in the vocal cords. So these are some of the pictures. We see a polyp here and a cyst, and there's another cyst in the vocal cords here. It's an intubated patient with the granulation tissue at the anterior end, possibly due to an intubation trauma. And here again, there's no intratracheal tube, but this patient has polyps in the posterior glottic area. This is possibly due to the trauma caused by the intratracheal tube like this, causing granulation tissue. It's a hemangioma in the anterior part of the vocal cords. So all these conditions are benign, but they might require surgical excision to get a better voice and for them to breathe comfortably. Neoplastic lesions can be papillomas. We have seen the pictures, chondromas, hemangiomas, and fibromas. Then malignant lesions of the larynx can generally squamous cell carcinoma, but adenocarcinoma, sarcomas, and abdominal sarcomas can also occur. Benign tumors can present with hoarseness of voice, and if they are big enough, like laryngeal papillomas, can cause stridor. Direct laryngoscopy will identify the problem, and direct laryngoscopy and biopsy or microlaryngoscopy will confirm that which can do to get histopathological diagnosis. This is a picture of a laryngeal papilloma within intratracheal tube. So the patient is awaiting excision of the papilloma under general anesthesia. It's a picture of the chondroma of the thyroid cartilage, a smooth swelling above the level of the vocal cords, and the vocal cords got pushed medial. So carcinoma of the larynx in the early stage can present with hoarseness of voice. So hoarseness is common to even benign conditions of the larynx. And the worst cases, when the tube has expanded and caused airway obstruction, they can present with stridor. Investigations ideal can examine most of the problem. Direct laryngoscopy and biopsy can be done to confirm the diagnosis. In the early stages, the carcinoma of the larynx can be excised endoscopically, or you can give radiotherapy. In the advanced stages, when they present with stridor, or if they recur with after radiotherapy, we have to remove the entire larynx, called laryngectomy. When you lose your larynx, you also lose your speech. So then we have to do rehabilitation, speech rehabilitation. There's a thing called esophageal speech. We can train the patient to develop esophageal speech. Or we can give them electronic larynx, battery operated electronic larynx, which they can hold to their neck and speak. Or we try to insert a valve called tracheoesophageal valve. So this is a picture of a carcinoma of the larynx showing the irregular appearance. So direct laryngoscopy and biopsy will confirm the diagnosis. And this is a leukoplakic lesion in the larynx, which might need excision and surgical confirmation to rule out malignancy. DLM biopsy is done when you suspect a larynx, and if they come with stridor, we will need tracheostomy prior to the DLM biopsy. Laryngectomy for very advanced laryngeal cancers, plus or minus cervical block dissection, combined with radiotherapy and chemotherapy can be considered on oncological advice. This is how it appears after the larynx has been removed and the cut end of the trachea has been brought forward and sutures to the skin. So we call it tracheal storm. So the patient can comfortably breathe through this, but only thing there is no speech, and one must avoid water getting into this area because it might go all the way to the tracheobronchial tree. So speech rehabilitation of laryngectomy, there are three techniques: esophageal speech, tracheoesophageal valve insertions, and electronic larynx. So this is the principle of valve insertion. This is the opening of the trachea into the anterior skin, and then we puncture the posterior wall of the trachea and the anterior wall of the esophagus and put a one-way valve called voice prosthesis. The patient has to be trained to speak using the voice prosthesis. And this is the appearance of that valve. And this kind of valve has a lifespan, so they have to be replaced at regular intervals. Some valves are removed You can replace every 6 months. Some players will remove practically every month. This is the appearance of the electronic larynx, which you can, it's battery operated, so you can keep it onto your neck and try to speak when you don't have a voice box. Thank you very much. So as a take-home message, remember the hoarseness of voice should not be ignored. It can be acute or chronic. Acute generally due to trauma or infections. Chronic can be due to a benign condition like vocal cord nodules or cyst or polyps, or but can be due to a malignant condition like a squamous cell carcinoma or a vocal cord palsy. Vocal cord palsy can be idiopathic or it can be secondary to a malignancy. So it's important that every patient with hoarseness of voice should have a proper ENT examination done. Vocal cords has to be visualized either with the indirect laryngoscope or using a fiber optic laryngoscope, and a clinical diagnosis should be made. And depending on what is seen, one may need to get a histopathological diagnosis by taking a biopsy. Thank you very much.